The incidence of dementia at the moment is considered to be about 330,000 people with some form of dementia, and of those we expect that at least 40 to 50% would be Alzheimer's disease. That's the most common, but there are about 100 different causes of dementia, including Alzheimer's disease most common, then vascular dementia, frontal lobe dementia, Lewy body dementia and some others. Younger onset dementia in Australia is also relevant. We have about 25 to 30,000 people they consider to have younger onset, say in the 50 to 60-year-old age group, and sometimes even younger. But they're often related to diseases such as Huntington's chorea or some sort of family neurodegenerative disease. That's a very difficult question in that identifying dementia is probably one of the hardest things for GPs to do, because they're often involved in chronic care management of that patient. They might have cardiovascular disease, which does impact on dementia. They may be involved in managing their arthritis and other disease conditions, and may miss the subtle changes of that person, either their memory, or they just don't seem to be doing things as well. They decide not to play bowls because they're getting a bit forgetful. So often those changes are very subtle. They may take 1 to 2 years before it becomes obvious to the GP and or their carers and or the friends of that person. We also have to understand that some of the patients you have might actually have nobody living at home with them. It's considered to be about 25% of people in Australia may be living alone, particularly the older person. So it may be the neighbour or the pharmacist who allude you to the fact that they're concerned about Mrs. Smith, Mrs. Jones, because she's sort of not the same. She's forgetful, she's not taking her medicine, she keeps coming to the pharmacist to pick up something that she'd already picked up a week ago. So I think for the GP it's often very difficult to pick up that problem. Some patients obviously do come in and talk to you about they're a bit concerned, they're worried about their memory, or they've come in with their husband, wife or partner, or maybe their daughter or son, and saying that, you know, Bob tells me that I'm getting a bit forgetful, I can't remember the kids' names anymore, and it's very upsetting. Maybe there's something wrong with my memory. That unfortunately doesn't happen as often. So it's often the point of the GP doing things, not understanding why blood pressure's not improving. They give them the medicine, check with the pharmacist and find out, you know, they're not picking it up, or I don't understand, I haven't been here for 3 months to get the repeat prescription. And because of the pharmacy-doctor relationship in Australia, you don't often have good communication in big cities. Perhaps in country towns you do have a better opportunity to find that person a bit earlier in their dementia pathway. One of the biggest challenges will be the fact that because of the ageing population, we GPs of the last 40 years and our specialist colleagues have made people live longer, getting better access to medicine, to medical treatment, to joint replacement, and therefore people living longer means statistically there'll be more people with some form of dementia in the community. So for GPs, I think they should be more aware of the fact that they'll start seeing people with cognitive problems, functional memory problems, and I think picking that person up a bit earlier will improve their management of the patient and therefore outcomes for the population that they're looking after. Happily, what's happening today is that most GPs are aware of advanced care planning, advanced care directive. So in some ways, if a person has been diagnosed or there's a suspicion of them having dementia, issues around that person's capacity to understand what's about to happen, what might be happening over the next few years. So on a legal side, one should be aware that if that person does have dementia, you need to discuss it with family, with carers, a person responsible, perhaps they're under a guardianship tribunal, trustee sort of situation. So medico-legally, I think doctors, once they're aware that this person has come back with a diagnosis of dementia, there are issues in some states of having to notify the road traffic authorities that this person perhaps shouldn't be driving. If they're making serious decisions about their finances, about purchasing, about moving somewhere, then I guess medico-legally again, does this person have the capacity to understand what are the consequences of making the wrong decision, and therefore noting in their records that this person has a problem, I then refer them to a specialist. Specialists come back with that confirmation that there is an issue of dementia here. So medico-legally, it's like any other serious disease. You need to talk it over with the family, with the carer, and with the permission of that person. With regard to coming back with a diagnosis of dementia from a specialist centre, a memory clinic, a geriatrician, I think we should be therefore noting that condition, talking to the patient. Unfortunately, some patients don't want you to tell other people they've got dementia because of stigma, cultural reasons, and I think it's important to note that in your records that they didn't wish to talk about it. There may be implications that they haven't notified, as I said, the Road Traffic Authority, and that is, in some states, the doctors here in Victoria and in Queensland should notify the Road Traffic Authority. This person's come back with dementia, they're concerned about their driving ability. So there are some actually quite serious medico-legal issues for doctors to follow, but at all times to note that they've made the diagnosis and had it assessed as being correct by a specialist memory clinic and or geriatrician, psychogeriatrician, and then look at the particular person's needs. If they don't want to be talking about it with other people, write that down. If they do, call in family, get their permission to talk about their condition with others. Again, you need consent. That person has rights. And they should be asked for their consent to talk about it with other people. I think that's an issue that doctors do have to accept is something they must consider. Well, having been with GPCE for many, many years, and then the last 3 years with the ALM, the Active Learning Module on Dementia, I think what's great is that we've dealt with here quite a few hundred GPs coming to listen, understanding dementia a little bit better, and then to go away and think about some of the patients that suddenly, oh gee, I may have to investigate that patient. So what I think is critical is they've got an opportunity to listen to some experts. I work with another specialist in dementia. We have an interactive workshop, people can ask questions, and often their colleagues give them some answers that they hadn't thought of, and or they're involved in an interactive workshop which creates education because they're reinforcing some of their knowledge and getting new knowledge. So I actually find this great, you know, I enjoy it, and I think, well, we get a high level of thank you, so we expect that they're actually enjoying it as well, and they walk away knowing something a bit more than when they walked in the door.